The next condition that we will consider today is pulmonary silicosis. Silicosis is currently the most prevalent chronic occupational disease in the world. It is caused by inhalation of crystalline silica, mostly in occupational settings. Workers involved in sandblasting and hard rock mining are at particularly high risk. Silica occurs in both crystalline and amorphous forms, but crystalline forms, including quartz, cristobalite, and tridymite, are by far the most toxic and fibrogenic. Of these, quartz is most commonly implicated in silicosis. After inhalation, the particles interact with epithelial cells and macrophages. Ingested silica particles cause activation of the inflammasome and the subsequent release of inflammatory mediators by pulmonary macrophages, including interleukin-1, tumor necrosis factor, fibronectin, lipid mediators, oxygen-derived free radicals, and fibrogenic cytokines. When mixed with other minerals, the fibrogenic effect of quartz is reduced. The name of the disease, pneumono ultramicroscopic silica volcanoconiosis, first described by Ramazzini, was changed due to the types of exposed dust. There are no reliable figures regarding the silica inhalation exposed population. Nevertheless, in 2000, the CAREX registry recorded 3.2 million silica-exposed people in the European Union. Silicosis is histologically characterized by highly ionized and fibrotic pulmonary nodules, accumulation of lymphocytes and alveolar macrophages, and thickening of pulmonary alveolar interstitium. The disease is caused by continuous inhalation of the silica dust, with marked inflammation and irreversible scarring of the lungs with nodules in the upper lobes. Oxygen and silicon together amount for 74% weight and 84% of crystal rocks, and they are the two most occurring common elements on the surface of the Earth. Silicon dioxide or silica is formed under the conditions of increased pressure and heat that exists in amorphous and crystalline form. The risk of developing silicosis is closely associated with the accumulated exposure of the person to respirable crystalline silica during his or her working lifetime. The intensity of accumulated respirable silica exposure can be calculated as the following accumulated silica dose that equals fractions of respirable dust that should be multiplied by percentage of free silica and then multiplied by number of years of exposure. Silicosis is the most frequently occurring pneumoconiosis due to wide prevalence in the atmosphere and more common than the other types of dust. Both in developing and developed world, silicosis is an occupational hazard with greater risk for workers engaged in stone crushing, stone cutting, cement industries, glass manufacturing, mining, agriculture, and construction. When the silica particles of 0.5 to 5 microns in diameter are inspired into the lungs, these particles get embedded into the alveolar sacs and ducts and cause inflammation. On the picture you see birefringent crystals between 2.1 to 4.2 microns in length that are identifiable in an intracellular location in alveolar macrophages obtained in bronchoalveolar lavage. The inflammation and scarring damage the pulmonary alveolar sacs, prevent gas exchange in the lungs, and contribute to abnormal breathing. The damage to the lung tissue leads to reduction of oxygen supply to the blood. Silicosis is an irreversible medical condition that does not have a cure. Degree of silica dust exposure is directly associated with occurrence of silicosis. Through the process of inhalation, different sizes of the silica particles deposit in the different parts of the human respiratory system. For example, 10-5 microns in size particles reach up to upper respiratory tract, causing rhinitis or laryngitis. 5 to 3 microns in size particles reach up to the mid-respiratory system and may cause tracheitis, bronchitis, and bronchiolitis. 3 to 1 microns to size particles directly are deposited in the alveoli, causing asthma, chronic obstructive pulmonary disease, and other pulmonary interstitial diseases, including silicosis. How silica particles stimulate pulmonary response and the precise pathophysiology of silicosis are still research questions. Nevertheless, several studies indicated interactions between respirable silica particles and pulmonary alveolar macrophages. In this interaction plays a major role in the development of the silicosis disease. The intensity of the inhaled silica particles influence on the nature and extent of the pulmonary alveolar response that provides explanation to some silicosis extension. Why rock drillers and sandblasters who are intensely exposed to freshly fractured silica dust develop silicosis disease. The silica promotes macrophage activation. The affected macrophage release inflammatory mediators and chemotactic factors that trigger cellular responses of the leukocytes and lymphocytes and then release the fibroblast stimulating factor. Helionization and collagen deposition are promoted by the fibroblast stimulating factor, FSF, and resulting in activation of fibroblast and pathologically pulmonary nodular lesion. This pulmonary nodule composes of a central acellular zone with free silica and surrounding spirals of collagen and fibroblasts. After ingestion of silica particles, pulmonary alveolar macrophages secrete fibroblast stimulating factor. Then macrophages die due to the toxicity of the ingested silica, and the silica particles are re-ingested by macrophages, and this process is progressively magnified. Lysosomal enzymes are then released rapidly into the cytosol and contribute to the breakdown of the intracellular organelles with irreversible injury to the affected pulmonary alveolar cells. Intracellular lysosomal rupture circumstantially results in cell death. It seems that damage of the plasma membrane results in macrophage death. Nevertheless, pathogenesis of silicosis may be associated with immunological mechanism due to identification of abnormal serum immunoglobulins and immunoglobulins in the silicotic nodules. Early pulmonary lesions are microscopically characterized by aggregation of dust-laden macrophages that surround a collagenous central region to develop nodular to stellate lesions. Then the central collagen distinctly becomes whorled and reveals decreasing number of inflammatory cells around the periphery. The pulmonary nodules shown on the picture are called mixed dust pneumoconiosis that caused by a combination of silica plus another dust. They are likely to persist as a stellate feature with less whorled arrangement in ordinary silicosis. Silica particle, particularly crystalline silica or cristobalite, can enhance the immune response, trigger, promote, or accelerate the development of autoimmune diseases. According to inability to break down the crystalline silica particles by lysosomal enzymes and damaging silica particle ingested pulmonary alveolar macrophages with its repeated process, this phenomenon results in spreading immune activity and pulmonary fibrosis. Dendritic cells, including T helper 17 cells and pulmonary alveolar macrophages, play a role in pulmonary inflammation and the development of pulmonary fibrosis. They are signaling molecules and specific receptor, although the role of dendritic cells and T helper 17 cells in the dysregulation of immune tolerance in patients with silicosis is poorly understood. TNF-alpha and the TNFR signaling pathway principal mediators in the development of silica-induced pulmonary fibrosis. Silica exposure can promote the production of several fibrogenic mediators that are potentially linked indirectly to fibroblast proliferation and recruitment of fibroblasts and proteases to repair the pulmonary damage. These fibrogenic factors may have a major impact on the intense fibrogenicity of silica. Silica exposure also promotes downstream signaling molecules related to fibrogenic pathway. Nevertheless, the mechanisms of silica-induced inflammation are not well understood. Silicotic nodule with refractile particles is a characteristic of silicosis, whereas presence of inclusion bodies like the asteroid bodies in non-caseating granulomas is typical of sarcoidosis. Silicotic nodules in their early stages are tiny, barely palpable, discrete, pale to black, if gold dust is present, nodules in the upper zones shown on the left picture of the lungs. And these changes are shown by the arrow. Microscopically, the silicotic nodule demonstrates concentrically arranged hyalinized collagen fibers surrounding an amorphous center. The word appearance of the collagen fibers is quite distinctive for silicosis, and this is shown by the the picture on the right. Examination of the nodules by polarized microscopy reveals weakly birefringent silica particles, primarily in the center of the nodules. As the disease progresses, individual nodules may coalesce into hard collagenous scars. The intervening lung parenchyma may be compressed or overexpanded, and a honeycomb pattern may develop. Fibrotic lesions also may occur in hilar lymph nodes and the pleura. There are three forms of silicosis depending on characteristic of silica exposure, clinical, radiological, and pathological features. Chronic, also known as classical silicosis, accelerated silicosis and acute silicosis, or silicoproteinosis. There are also several other conditions associated with silica exposure which result in considerable morbidity and mortality, including autoimmune diseases and tuberculosis. Chronic silicosis is the most common form and is subclassified as simple nodulosilicosis or complicated silicosis as progressive massive fibrosis. Chronic silicosis typically develops slowly, usually presenting 10 to 30 years after first exposure. Radiographic features may initially develop many years after cessation of exposure. Chronic simple silicosis is radiologically characterized by pulmonary nodules up to 10 mm in diameter, typically in the upper zones. Patients with simple silicosis may be asymptomatic and only detected by chest radiology, such as part of an occupational health screening program. On the picture, you see upper lobe predominant centrilobular and subpleural nodules in the dorsal aspect of the lung in this patient with simple silicosis. The severity of simple silicosis can be categorized by the extent of nodularity in the lung fields. Radiological perfusion. Simple silicosis is often symptomless but may be associated with cough and sputum production. On the right, on the top, you see the classic silicosis in a 53-year-old man who worked for 12 years in sandblasting. Micrographs show a transbronchial lung biopsy specimen image obtained with visible light shows intraalveolar aggregation of pigmented macrophages, shown by the arrows. On the bottom on the right, you see an image obtained with polarized light that shows scattered interstitial silica patterns, shown by the arrows. Progressive mast fibrosis characterizes larger opacities and involves an upper lobe predominantly and might be various in shape. There may be volume loss with tracheal and mediastinal distortion and development of parapsychiatrical emphysematous destruction. On the picture you see advanced accelerated silicosis with paracicatricial emphysematous, predominantly upper lobe distraction, shown by the red arrow. It may be difficult to differentiate radiological features from lung cancer, tuberculosis, and sarcoidosis. Lymph node enlargement is quite common and is shown by the stars on the picture. Calcification may also develop within the conglomerated masses and in lymph nodes. Distraction of lung tissue results in impaired lung function and elevated pulmonary vascular resistance. Clinically, patients experience progressively worsening dyspnea, hypoxemia, cor pulmonale, respiratory failure, and death. Following development of pulmonary silicosis, the disease may progress even after cessation of respirable crystalline silica exposure. Risk of progression has been associated with cumulative respirable crystalline silica exposure, young age, lower lung function, and larger size and extent of lung opacities on chest radiology at time of initial visit and follow-up duration. Accelerated silicosis develops less than 10 years after the initial respirable crystalline silica exposure and is associated with high-intensity respirable crystalline silica exposure than chronic silicosis. Accelerated silicosis has similar features to the chronic forms but is characterized by more rapid disease progression shown on the picture. The radiological features vary depending on the stage when the condition is identified and have not yet been well described. In the early stages of accelerated silicosis, plain chest X-ray may not detect diagnostic features. A study of Chinese miners noted 26.9% patients had a negative result on chest X-ray screening despite findings for pneumoconiosis on computed tomography. A preliminary report of artificial stone workers in Australia noted a normal chest X-ray in 43% with computed tomography finding of silicosis suggesting a low sensitivity of the chest X-ray in that setting. Acute silicosis differs significantly from chronic silicosis. Acute silicosis results from very high-level respirable crystalline silica exposure for a few weeks to 5 years. It has been described most commonly in sandblasters, but also in tunnel workers and silica flour processing. Acute silicosis is a progressive condition with non-specific symptoms including dyspnea, cough, fatigue, weight loss, fever, and pleuritic pain. Disease progression may be rapid and there is high associated mortality. Radiological features are limited to small case series and reports. CT findings include numerous bilateral centrilobular nodular opacities, focal ground glass opacities, and patchy areas of consolidation. On the left, you see a picture of acute silicosis in a 52-year-old man who worked for 10 years as a crystal craftsman. Computer tomography scan obtained at the levels of the ventricles show ground glass opacities and mild interlobular septal thickening, shown by the arrows in the middle and lower lobes on the right lung and the lingular division on the upper lobe of the left lung. On the right picture, thoracoscopic biopsy from the patient in the lingula shows a fine granular eosinophilic material that fills the alveolar space. Note the pigment-laden perivascular and interstitial macrophages and giant cells, shown by the arrows. The diagnosis of silicosis requires a history of sufficient respirable crystalline silica exposure, compatible radiological features, and exclusion of alternate diagnoses such as sarcoidosis, hypersensitivity pneumonitis, tuberculosis, and lung cancer. The diagnosis may be challenging where the radiological features of complicated silicosis, sarcoidosis, tuberculosis, and lung cancer are similar. In these circumstances, further investigations such as bronchoscopy with bronchoalveolar lavage and lung biopsy may be considered. Apart from silicosis, silica exposure is also associated with a range of other respiratory and non-respiratory conditions, including sarcoidosis, autoimmune disease, lung cancer, and pulmonary infections. Epidemiological studies have noted an association between silica exposure and sarcoidosis. In one of the most systematic reports, a study of 2,187 silica-exposed iron foundry workers in Sweden noted an excessive incidence of sarcoidosis, in particular among those with high exposure to silica dust. Especially in the early stages, silicosis and sarcoidosis display very similar radiological and pathological features, such as the presence of histiocytic aggregates and granulopatous inflammation. And in many cases, sarcoidosis and silicosis may be easily confused. Importantly, since sarcoidosis is a disease with no known cause, the diagnosis requires exclusion of other granulomatous disorders where the cause is known, and especially those such as silicosis triggered by environmental exposures. It is hence critical that in any patient presenting with granulomatous pulmonary disease, a very careful occupational history is obtained. If there is a potential for significant exposure to respirable crystalline silica, silicosis rather than sarcoidosis should be strongly suspected so that the opportunity to provide specific and potential life-saving advice regarding ceasing further exposure is not missed. Further diagnostic testing, like bronchoscopy with bronchoalveolar lavage, transbronchial or open lung biopsy, may be required to differentiate these two conditions. Silica is associated with several autoimmune diseases such as systemic sclerosis, rheumatoid arthritis, systemic lupus erythematosus, and anti-neutrophil cytoplasmic antibody-related vasculitis. A meta-analysis of 242 silica-exposed rheumatoid arthritis cases indicated that disease risk for exposed individuals was more than 3 times that of unexposed individuals, and the risk appeared to be higher in males. Although systemic sclerosis is less common than rheumatoid arthritis, several studies have demonstrated an increased risk of systemic sclerosis in association with silica exposure. An analysis of 16 studies examined the association between systemic sclerosis and occupational exposure to silica, noting a rheumatoid arthritis of 3% for males. The risks in the 3 studies included were extremely high, with over 15-fold higher risks. Patients with silica-associated systemic sclerosis had a great prevalence of anti-DNA topoisomerase or 1 outer antibodies compared with those with idiopathic disease. One of the primary causes of morbidity and mortality in silica-exposed workers is the development of Mycobacterium tuberculosis infection. The risk of a patient with silicosis developing tuberculosis is higher than for healthy controls. Tuberculosis rates are extremely high in silica-exposed workers from regions with high background rates of tuberculosis and HIV. South African gold miners have pulmonary tuberculosis rates of 3,000 per 100,000. TB infection is associated with an increased risk of silicosis progression and disease severity. The effects of tuberculosis are also aggravated by HIV infection and smoking, which commonly coexist, especially in developing countries such as South Africa. Silica exposure increases the risk of tuberculosis, even without silicosis, and continues after exposure has ceased. Clinical management can be difficult as the radiological features of silicosis and TB frequently overlap. International guidelines recommend tuberculosis screening for silica-exposed workers, especially over 10 years of exposure, and chemoprophylaxis for latent tuberculosis in the setting of silicosis. In 1995, the World Health Organization began a campaign to eliminate silicosis from the world by 2030, but silicosis remains a major health issue internationally. In 2016, The global burden of disease study estimated 10,400 deaths per year and 210,000 years of life lost due to silicosis. Between 91 and 95, there were more than 500,000 new cases of silicosis in China. The industry with the highest contribution in China was mining, with an estimated prevalence of 6% among coal workers. About 12% of cases came from the metallurgy and 8% of cases from construction material manufacturing. In 2003, the South African mining industry committed itself to eliminating silicosis, the target being no new cases by 2013. However, there was no significant decline in overall silicosis prevalence among cohort of working gold miners in 1984 compared with a further study between 2000 and 2009. In high-income countries, due to improvements in dust control measures, there have been reductions in the incidence of silicosis over the last 50 years. In the UK, between 1996 and 2017, there were 216 cases of silicosis reported to a surveillance program and an estimated 700 cases for the country as a whole. The mean age was 61, but the youngest was 23. In the United States, there were an estimated 3,600 to 7,000 newly recognized silicosis cases per year from 1987 to 1996. Death certificates between 1990 and 1996 noted 200 deaths per year contributed to by silicosis. In recent years, 2 of the worst outbreaks of silicosis have occurred in industries not traditionally thought to be associated with respirable crystalline silica exposures, specifically denim jean production and domestic benchtop fabrication. The process of sandblasting denim jeans to produce a worn-out look began in Turkey in the 90s and reached its peak in the early 2000s. The first case of silicosis in the industry was identified in 2001. A study of former workers noted 77 of 143 to have silicosis at baseline. After a 4-year follow-up period, 9 had died with a mean age of just 24 years. Of the 74 living sandblasters available for re-examination, the prevalence of silicosis increased from 53 to 96%, and radiographic progression was observed in 82%. Since the early 2000s, artificial stone has rapidly become a popular material for the fabrication of kitchen and bathroom benchtops. Artificial stone is a composite material made of quartz as the major filler, with the addition of colored glass, shells, metal mirrors bound together by a polymer resin. The crystalline silica content of the material is over 90%, which is far higher than traditionally used natural stones such as granite or marble. Slabs of artificial stones are modified by workers based on client specifications, which include producing cutouts for installation of cooktops, sinks, and tapware. Cutting and grinding the material without water dust suppression, so-called dry cutting, has been commonplace and is associated with generation of potentially extreme levels of respirable crystalline silica. One study noted dry cutting artificial stone produced 44 milligrams per cubic meter of RCS over 30 minutes, close to 300 times above the recommended 30-minute exposure limit. Another study noted that grinding artificial stone produced respirable dust with a silica content of up to 93%. The first reported case of silicosis associated with artificial stone was from Italy in 2010, and recently the number of cases reported internationally has grown rapidly from countries including Israel, Australia, Spain, and the United States. These reports have noted younger age of diagnosis and more rapid disease development than chronic silicosis, and a high rate of disease progression and resultant death or requirement for lung transplantation. Data have also indicated a 7-fold excess prevalence of autoimmune disease in patients with artificial stone-associated silicosis in Israel. Out of 40 patients with advanced silicosis, 9 were diagnosed with autoimmune diseases, specifically systemic sclerosis, mixed connective tissue diseases, rheumatoid arthritis, Sjogren's syndrome, and poliomyositis.